Okay, we're going to talk about the neurological assessment, the assessment that you'll be doing in your clinical exam. And we're also going to be covering some topics which hopefully you find are interesting and helps to clarify your understanding of some of the elements of neurological testing, and particularly in relation to sensory testing. So just to make it clear, in POD3PPC you had this type of assessment where you're looking at signs and symptoms, monofilament testing, vibration testing, PPC. You will see you've got a lot of similarities in PPD, vibration perception testing, monofilament testing, visual inspection, pretty similar to your signs and symptoms. We'll talk about that later. But you'll also be covering reflexes and muscle strength testing. Reflexes are a little bit difficult, but we'll show you a little bit on how to improve your testing of reflexes, and something you can practice in clinic. So to just cover the first stage of your neurological assessment, to achieve satisfactory in this assessment, you need to be able to outline most or at least important visual cues to assess neurological status. You'll see that it's focusing on visual cues rather than just symptoms. You're probably used to talking about pins and needles, people with paresthesias or shooting pain down into their feet or legs. But when it comes to visual cues, it's a little bit trickier. So the visual signs are muscle wasting in some people. So you might see this in diabetes, Charcot-Marie tooth disease. And if you don't know what Charcot-Marie tooth disease is, it's an inherited neurological condition, primarily affecting the motor nerves of the periphery. You'll be covering this in more detail in some of your other subjects, particularly in fourth year. But it's inherited, and it is the most commonly inherited peripheral nervous system disorder. So it's roughly 1 in 2,000 to 1 in 8,000, depending on which country you're talking about. People with spinal problems may end up with muscle wasting because they have compression of nerves, so that's what we often call radiculopathy. Then we've got people with multiple sclerosis or motor neuron disease, separate obviously conditions, but these people can also present with muscle wasting. So muscle wasting overall is one of the visual cues. I would recommend you have a look at some images of Charcot-Marie tooth disease, because you will see the profound muscle wasting that occurs in this condition. So have a look on Google and you'll find some interesting presentations, particularly around the lower part of the leg. A cavus foot structure is also associated with neurological conditions, particularly when it occurs in young people. So babies or young people getting to walk, if you notice they've got a very cavus foot structure, this is highly correlated with the neurological problem. And quite commonly this may be associated with something like cerebral palsy. Extremely flat foot conditions where you have paralysis can also be a sign of neurological problems. Obviously not always, but in some situations you may find people have diseases or issues that lead them neurologically to develop an extremely flat foot. Tremors. So occasionally you might see patients with Parkinson's disease who have tremors, not to be confused with an essential tremor, which can happen idiopathically as we get older. Then there are also gait abnormalities. And this is one of the ones that's often forgotten in a clinical exam, because the patient will be in front of you sitting in the chair, and it's quite easy to forget that you may not be thinking about their gait when they walk into the clinic. So gait abnormalities may be something you pick up on as the patient walks into the clinic. Red feet, highly red feet, can be a sign of autonomic neuropathy. So your arteries, arterioles, are controlled by your sympathetic nervous system. And if this system is not working properly, because you have neuropathy of the autonomic system, then you may end up with significant vasodilation. Dry skin. This can occur in diabetes because of autonomic neuropathy. So diabetes can lead to pathology in nerves, and particularly in autonomic nerves, and that can then lead to loss of sweating, because your sweat glands are controlled by your sympathetic nerves. Also, don't forget that autonomic nerves are involved in other parts of your body, including gut function and heart function. And so people with diabetes who develop autonomic neuropathy can also develop internal organ changes as well. Now, we will just mention here the symptoms, and clearly you'll be quite capable of mentioning tingling, numbness and pain. Tripping is another one, and general balance problems and clumsiness. These are other symptoms that can occur, or signs that can occur associated with neurological problems. Now, I noticed that a lot of students aren't particularly familiar with the fact that we have different nerve endings. So on the ends of your nerves, so if you imagine, as I do, that we have branches from our tree, and at the end of those branches we have the fine twigs or leaves, and on the end of those we have, in the case of the neurological system, specialized receptors that are particularly designed to pick up certain types of sensation. So you may not have to recall these in your exam, but it's good to know that there are different sensory nerve endings for different things. So the Meissner's corpuscle, for example, which is one you should be aware of, is involved in light touch and textural sensations. Merkel's disc endings are involved in longer touch and pressure. So the Meissner and Merkel receptors are particularly involved in the monofilament because that involves light touch and pressure. Krauss end bulbs, probably something that you're not going to think about too often because these are possibly involved in cold perception and light touch, but not so much as the Meissner and Merkel disc endings. So it's also worth being aware that Pacinian corpuscles are another one that's very significant, and these are involved in deep pressure and particularly with vibration. So if you look over to the right here, we have the Pacinian corpuscle, and you will notice that it's like an onion bulb, has many layers to it. And these Pacinian corpuscles are actually embedded deeper in the skin. You'll see they're not towards the surface, they're actually deeper in the skin, and in fact they're actually embedded into the bone in the periosteum. So the skin around the bone also has Pacinian corpuscles. So when we apply a tuning fork to a bony prominence, those Pacinian corpuscles in the bone can help pick up that vibration. Ruffini's endings, which are involved in stretch and warmth, and free nerve endings, which are basically unspecialized. So they're just simply over here. We've got the free nerve endings. They have no specialist adaptation at all, and they're involved in pain, temperature, and basic touch. So we're just going to cover some of the things around nerve fiber types, their size and conduction. This may be a bit of a refresher for you. If not, hopefully you'll pick up a few tips around it. So when it comes to different nerve fibers, we actually can class them into different groups based on their size. So nerve fibers are classified based on diameter, myelination and conduction velocity, and the diameter, the myelination and conduction velocity are all related. So the diameter of a nerve is increased if it has more myelin around it, and the conduction velocity of a nerve is also increased if it has more myelin as well. So basically, the thicker the nerve, the more myelination, the greater the conduction velocity. And so when we look down here, you'll see the A alpha nerve fibers, which are the largest in the peripheral nervous system, and they have quite a large diameter, so up to 20 microns, and they also have an incredibly rapid speed of conduction. So your A alpha fibers will be able to transmit a sensation from your toe, for example, to your brain at a speed of around about 200 miles per hour, When we look at the C fibres at the other end, now C fibres have no myelin at all. And these are really slow conducting fibres relative to A alpha. And so it's going to take around about 2 seconds for a nerve signal to go from the toe to your brain in the average height person, because these are travelling at around about 2 miles per hour versus your A alpha, which is roughly travelling around about 200 miles per hour. Now, as I will note in a further slide, when we look at skin sensation occurs through the A beta fibres. So if you can remember that the A beta fibres are the ones where your specialised nerve endings are attached to in the skin. They go through that A beta fibres. So they're still very rapid fibres. So as I've said, just to summarise that again, A alpha fibres are the fastest conduction, and they're involved in motor and proprioception. A beta fibres, medium myelination, touch, vibration and pressure sensation. A delta fibres, they're involved in sharp pain and cold temperature, not so significant in regards to the sort of test you're going to do in the lower limb. And then we've got C fibres, which as we discussed, are very slow conducting, dull pain, warmth and autonomic function. So your sympathetic and parasympathetic nerves are unmyelinated, and they're quite generally slow in the way they function. I also want to just quickly review the timeline of myelination after birth. And this is, I think it's quite interesting. So your peripheral nervous system is not fully myelinated at birth, and it basically doesn't become fully myelinated for the first couple of years. So around about 2 years of age, your peripheral nervous system has completely myelinated. Your spinal cord also hasn't fully myelinated at birth, so this also takes a couple of years. Your brainstem is fully myelinated by about 2 years. Now, there are some pathways within your spinal cord, and you can look these up, the corticospinal tracts, the DCML tracts, and the spinothalamic tracts. Now, what's interesting about these is that they're largely myelinated by 2 years, but the fine motor pathways continue to refine until adolescence. So I think the interesting part about this is that we can't expect normal motor control in the first couple of years because we don't have that appropriate myelination. But we should also allow for the fact that that full myelination that allows really fine dexterous control doesn't finish until adolescence. So you will continue to get better and refine your ability to control fine movement as you get into your teenage years. So you'll naturally progress and you will use your muscles in a more appropriate way as you get older. So I think the takeaway point here is that your nervous system that controls your muscles isn't fully developed at birth, and you will continue to improve and progress right up into adolescence. And so the way you participate in sport and control your movements in sport are going to change as you get towards those teenage years. So I know we've mentioned this already, but I just wanted to highlight the fact that the A beta fibers have all of these things attached to them. Now, there are some muscle spindles, but you will see that muscle spindles, and it's worth looking this up if you've forgotten about what muscle spindles are. So muscle spindles are the little sensors inside your muscles, very important for reflexes, which sense the length and tone of your muscles. And this is super important because this is basically a mechanism which is used by the body to control the tension on your tendons. So your muscle spindles provide information to the brain about the length of your muscle to ensure that you're providing adequate tension on your tendon, which is really important for walking and running and all body movement. Your Golgi tendon organs, let's just say they have a similar function. They're a little bit slower than the muscle spindles, but they're also important in muscle function. Now, there are some muscle spindles which are also attached to the A beta fibers, but what I want to highlight though is that the Meissner corpuscles, the Merkels, the Pacini and Ruffini, Krauss-Hand bulbs, and something called your hair receptors are also on the A beta fiber. So primarily most of your sensory receptors are attached to that medium speed fibers. So I'm going to say it once again. Larger fibers conduct faster due to reduced resistance and increased myelination. So the myelination, if you can't remember that part, myelination helps the saltatory conduction, or the jumping of action potentials along the nerve. And basically, the thicker the myelin, the faster it is. And small unmyelinated fibers conduct more slowly, leading to delayed perception of pain and temperature. So just purely for interest's sake, on the surface of your eyeball, you have basically around about 80 to 90% C fibers. Now, if you ever poke yourself in your eye, you will notice the fact that you can feel pressure and you can feel pain and you can even feel temperature on the surface of your eyeball. So C fibers are capable. So these are essentially free nerve endings. They're not specialized in any way. These are just free nerve endings which innervate the surface of your eyeball. And it basically demonstrates that even though they're not specialized, you can still perceive certain types of stimuli on the front of your eye. So let's talk about vibration testing. So, as we've mentioned, vibration testing primarily stimulates the Pacinian corpuscles, so it's probably good to remember the fact that when it comes to vibration testing, you need that word Pacinian ideally, which are in the deeper skin structures and bone. And they're conducted, as I've said, through the A beta fibers. Now, it's also worth noting that there are different types of tuning forks. When you pick up a tuning fork, you will see that there is actually a number on it, and you may see that some of them have got 64 Hertz, some of them got 128, and some of them have got 256. Now, as a general rule, in neurology, most neurologists will use a 128 Hertz tuning fork. Now, the 128 Hertz tuning fork has just become a standard. Now, it's not to say it's the best, it's just become the incumbent standard used in most neurological assessments. Traditionally, though, it's been noted that the lower limb has generally, it's okay if you can feel the vibration around 64 Hertz in the lower limb. And the reason they've used 64 Hertz, the slower vibrating tuning fork in the lower limb, is because there isn't as much density in the nerve endings in the lower limb, and so you don't have the same resolution and definition in your feeling in the lower limb as you do in your hands and fingers. So the lower limb historically has been relegated to 64 Hertz, and the upper limb is 128 Hertz. Now, most neurologists will use a 128 Hertz tuning fork. Now, if you don't know what Hertz means, it's how many times the tuning fork moves backwards and forwards in a second. So a 128 Hertz tuning fork will vibrate backwards and forwards 128 times in 1 second. And if you happen to be a musician, you will know that different frequencies align with different notes. So 64 Hertz, for example, aligns with the second C on the piano, 128, the third C on the piano. And there's also another tuning fork which I'd highly recommend that you become familiar with because it's actually quite useful. And that's the 256, a higher frequency. And what they've found in a number of recent studies is that people who can't feel 256 Hertz vibration, it quite often indicates in the lower limb that they may have a spinal nerve root compression problem. So you have a lumbar spine that's getting a bit old, or you've had an injury and you've got a bulging disc and it's squashing a nerve, that can actually lead to, first, a loss of 256 Hertz frequency. So they might find that they can feel the 64 or the 128, but they can't feel the 256. So just keep that one up your sleeve, just so you can have a little bit more, another option for testing patients, and I use that quite regularly in my practice. It's also worth noting that there are two different types of tuning forks. There is basically the weighted and the unweighted, and there's not a big difference. They still have the same vibration rate, but the weighted tuning fork, and you can see the weights at the top here, means that the actual tuning fork vibrates for a longer period of time. It's not essential, it's not going to make a big difference, but just so you know, if you're looking at buying tuning forks, there is both weighted and unweighted versions of them. So we're just going to talk briefly around vibration and monofilament testing. And the big question is why would we test both? Now, vibration goes through the A beta fibers, just like the monofilament tests pressure, and that also goes through the A beta fibers. So it's testing the same fibers. However, vibration has been shown in a lot of cases to start to disappear earlier than pressure sensation. So vibration has been shown to detect early in neuropathy. And as I'll mention in just a little bit in another slide a little bit later, this can also be associated with proprioceptive loss. Now I'll explain that in just a little while. When you lose pressure, then it can indicate that we've got moderate to severe sensory loss. So again, vibration is early, pressure sensation is probably a little bit later. Now, these are not hard and fast rules, but this is generally what we would consider to be a fairly common idea or concept in the industry. So vibration may be used for early neuropathy screening. You may pick up spinal cord issues, as we spoke about before, with the 256 hertz tuning fork, and you can actually pick up people with B12 deficiency, which is well known for causing loss of vibration sensation. When we're losing pressure sensation, then we start to particularly develop risks of foot ulcer. So we'll go over this in just a moment, but basically when we are testing pressure sensation in our clinics, we are using the 10-gram monofilament. So that basically means that you've lost something called protective sensation, but I'll clarify that in just a moment. So just to recap, vibration probably detects earlier nerve damage, whereas the monofilament probably predicts a bit more accurately functional impairment and risk of injury. Now, just another thing to add into the complexity of this is that as we get older, we all lose vibration sense to some degree. So it's all just a natural part of the aging process. So it's considered roughly normal to lose about 20% of your sensitivity in vibration once you get to about the age of 70 or 80. So we have to allow for the fact that as we age, we are naturally going to lose some level of vibration sense, and that typically reflects itself into the fact that our other sensory nerve endings, such as our proprioception, are also going to be dropping as well. And so as a consequence of this, you may find that people as they get older have issues with balance, partly because they're losing that sensory feedback, and that also comes from their proprioceptive loss as well. So the key takeaways are vibration testing is often lost first in conditions like diabetes, making it an early warning sign of neuropathy. Monofilament testing often detects more advanced sensory loss and is a better predictor of injury risk. So using both tests together gives us a better picture of nerve function across different stages of the disease. So just to round this off, vibration testing assesses sensation which occurs through the medium to larger myelinated A beta fibers, and these fibers are also responsible for the processing of proprioception or some levels of proprioception. So when we get a loss of vibration sense, this can also indicate that other nerves are affected, and so we may get some level of proprioceptive change, not always, but we may, and this is quite common in people with diabetes and people with vitamin B12 deficiency. So if vibration sensation is altered, maybe other large fibre sensations are affected also. So when we look at your clinical exam, you need to be able to demonstrate the technique of applying a tuning fork, and you can practice that in clinic, but you also need to explain the reason to perform vibration perception. And the reason is to detect sensory loss, and typically this sense goes before the loss of other sensory tests. So you're going to say the reason is for the earlier detection of sensory changes. Now I know you've done this before in other classes, but just to go over it again and reinforce a couple of points, I'm just going to talk about the monofilament. And in our clinic, we use the 10-gram monofilament, also called the 5.07 monofilament. Now, I want to make a really good point here around the fact that when we look at the Semmes-Weinstein monofilament set, it actually comes in 20 different strengths, if you like, or different levels of pressure. Now, one of the things that's often missed by students is that the 5.07 filament, the one that you're using in clinic, applies 10 grams of pressure against your skin. And of course, when you apply it to the foot, and you can see here when it buckles, when it bends, and you're applying it slowly and holding it there for a few seconds, you're applying 10 grams of pressure. Now, it's not specifically 10 grams, and you can actually measure it. If you're wondering, you can take your monofilament and apply it to a set of scales which have a gram scale on it, and you can see how much it's actually applying to it. And it won't be exactly 10 grams. It'll be roughly about 10 grams of pressure. But the key here is also the fact that 10 grams of pressure, when you cannot feel 10 grams of pressure, that indicates that you're likely to have lost your protective sensation. Now, this is not a measure of normal sensation. If you have normal sensation, generally you should be able to feel 0.4, less than 1 gram of pressure against your skin. Now, if it's a baby's foot, they're going to be able to feel even less than that, 0.07 grams of pressure. So this is normal sensation way back here. Protective sensation is way down the track, where the normal sensation has been lost, diminished light touch has been lost, diminished protective sensation is lost, and now we've actually lost protective sensation. So 10 grams is really a long way down the track for people. But it's become the standard particularly in podiatry for detecting those more severe changes of sensory loss. Now, just so you know, if you're working in a warm environment, then it will heat the plastic up, so that the room temperature will affect the flexibility of the plastic as well as the humidity as well. So depending on the environment that you're in, it will change the amount of pressure you're applying to the skin, and even is going to change the texture of the skin and the flexibility of the skin. So there are a number of factors here which are going to vary the result. So a cold foot or a hot day is going to change the result you're going to get. Not tremendously, but do take into account the fact that this does affect your ability to do this test. So when we look at those studies, they're all done where the patient has been sitting there for half an hour, and they've got their body sort of got used to a certain temperature, and that's typically 25 degrees, and it's done in that nice controlled environment, which is not the same as when you're in clinic. So when we look at your neurological exam, again, so explaining the reason why you do a monofilament test, and it's to detect sensory loss and typically loss of pressure sensation, which places the patient at greater risk of ulcer development. So that's why you're doing this particular test. Now we're going to talk about reflex testing here. Reflex testing is quite difficult to do. Now the patella test you'll find is no problem at all. It's a fairly simple test and easy to position the patient. The Achilles test is a little bit trickier, and then there are a variety of positions that you can put the patient in to do an Achilles test, and you'll see one particular position here, and there are sometimes you have the patient with their legs hanging over the edge of the chair. The key things to pick up from this picture, you can see that the practitioner is putting their hand against the front of the foot and providing gentle pressure to provide a bit of tension on the Achilles tendon. And then you will notice that they're striking the Achilles tendon with the hammer, the reflex hammer, with the circle aligning up with the Achilles tendon. So this is probably a nice way to try to reproduce an Achilles reflex. If you get very good at reflex testing, and this takes a lot of practice, then you can actually start to grade your reflexes. So no reflex, that's fairly easy. At the other end of the spectrum is a grade 4 reflex, where there is not only a really strong hyper reflex, but there's also the foot will go into clonus. It's basically a tightening up of the foot, which typically is a sign that there might be some sort of brain lesion or spinal cord injury occurring. So what you're typically looking for is a normal middle of the road sort of reflex. So you won't probably get to a stage where you're able to discriminate between a 1, 2, 3 or 4, but you might be able to discriminate between a normal and a 0. So when you're looking at reflexes, what I do want to make a point of is talking about how a reflex actually works. And you've probably covered this before, but there's no harm in doing it again. So when you're conducting a reflex test, you're basically hitting up against the tendon, and that's causing the tendon to stretch and put tension on the muscle spindles. Now that actually triggers off a response in the muscle, because what happens is that you've stretched the tendon so quickly that it makes the muscle spindles think that you're about to injure the muscle. And so this triggers a reflex response where it goes up to the spinal cord, that sensation from the muscle spindle, because that is the sensory organ in your muscle. It provides a very quick response up to your spinal cord, and then that connects with a motor nerve which comes back to, in the case of the patella reflex, it comes back to the quadriceps and it causes them to contract, and essentially it's a guarding mechanism to say, don't injure the muscle. So I'm being stretched rapidly. Geez, if you keep doing this really quickly or even more, you're going to pull the muscle apart. So I better protect myself, and so it triggers off that muscle to contract, which will cause the knee to extend. Now, in addition to that, it will also cause the muscle on the opposite side from the quadriceps, so your hamstrings, to relax. So that's called, as you may know, reciprocal inhibition, whereby one muscle contracts and it causes the other to relax. So when you're doing a reflex, it's not telling you which part is actually working or not working. It's just telling you the fact that the loop is actually occurring. Now, in the cases where you have a significant reflex or a hyperreactive reflex, then that basically can be an indication that there is actually some sort of brain lesion, brain tumor potentially, which is causing you to get hyperreflexive. And this can also occur in some other conditions like ALS, which occurs in the spinal cord. And if you have obviously a case where you've had a spinal cord injury and you've crushed a nerve, then obviously you won't get a reflex at all. So in diabetic neuropathy, this causes reflex loss by damaging large sensory fibers. So the muscle spindles might be damaged, or the actual long fibers themselves, so the axons, are actually damaged as well. So the Achilles tendon reflex is usually lost first, and this is S1 to S2, so sacral 1 and sacral 2, due to its dependence on large fiber function. And as this progresses, it can actually get worse and eventually incorporate the patella tendon reflex as well. So you may lose both your Achilles reflex as well as your patella tendon reflex. It takes a lot of practice, so I'd highly recommend that when you get a chance in clinic to practice doing reflexes on each other, or preferably if you can buy yourself a tendon hammer and go home and practice doing some reflexing on your friends and family. That'd be great, because the more you do it, the better you'll get. It's also worth just mentioning just something about something called PNF stretching. I'd like you to look that up. Basically, it's a fantastic way of learning how to improve your ability to stretch a muscle. That involves confusing both the muscle spindles and the Golgi tendon organs. But if you look into that, it's worth looking up PNF stretching. It sort of relates a little bit to reflexes. And so it's a worthwhile thing if you're trying to help patients to improve their flexibility. Now, if you really want to improve your knowledge around reflex testing further, it's worth mentioning something called the Gendrasik maneuver. So this is a Romanian neurologist, a very clever fellow from the 1800s, who came up with the idea of clenching your teeth or pulling on your hands, as you can see in this picture here. And this basically enhances the reflex. So if you find that you're struggling to get a reflex from a patient, you may find that asking them to do the Gendrasik maneuver is quite useful. So it's fairly easy to do. They just cup their hands together, pull it apart whilst you're doing the actual procedure or doing the reflex. And basically it changes the way what we call inhibitory neurons actually connect with the motor nerves in your spinal cord. So basically it frees up the reflex to happen more easily. So Gendrasik maneuver, it's a good one to know. In addition to that, you'll also notice that there are different types of tendon hammers. So in our clinic at La Trobe, we have the tomahawk hammer, called the tomahawk hammer for an obvious reason. That looks like a tomahawk axe. Also called the Taylor hammer, named after John Taylor. It's one of the first tendon hammers invented. Particularly in America, they like to think of themselves as having invented the first tendon hammer. In fact, it wasn't first invented there. But there was an improvement in the tendon hammer, and there are two types of tendon hammers, and you'll see these also in the clinic. There is the Babinski hammer. You'll know Babinski from the Babinski reflex, another well-known neurologist, and there's also the Queen Square hammer. Now, the Queen Square hammer is named after the Queen Square Hospital in London, and this particular hammer, as you can see, it's got the circle on the top, rounded edges, has a slightly longer shaft. It generally works a little bit better for Achilles reflexes, so I'd recommend this one. And it is most preferred, pretty much around the world. It's the preferred hammer. So if you are struggling to get a reflex with the tomahawk hammer, have a look at trying the Babinski hammer or the Queen Square hammer, basically the same hammer, in clinic. And it's roughly about 70 to 80% of neurologists use that type of hammer. So we're just going to cover muscle spindles versus GTOs, or Golgi tendon organs, again. So muscle spindles are special sensors in muscle to detect change in muscle length, stretch, if you like. So they initiate reflex through the spinal cord. They activate motor neurons, and muscles contract to resist excessive stretching. So therefore they maintain muscle tone and posture. Golgi tendon organs in tendons do not mediate the stretch reflex. They detect overall muscle tension, not length, and inhibitory signals to spinal cord reduces the muscle contraction. So just imagine you're doing a really strong stretch and you're trying to really stretch the muscle to make it longer. The Golgi tendon organs will feel that tension in the muscle, and they'll actually contract the muscle to stop you from overstretching it. Otherwise, you potentially could pull the muscle apart. So the main points here are muscle spindles are involved in muscle stretch and length, whereas the GTOs or Golgi tendon organs are involved in the actual just general tension in the muscle. So just to continue on from reflexes and in regards to balance testing, so we need to be able to demonstrate the technique and explain the reason for doing the reflexes and to assess ankle and knee reflexes. So you can no doubt assess ankle and knee reflexes by doing practical testing on each other. The reason we're doing this is really to detect whether someone's actually lost a reflex. So quite commonly in diabetes, we will get a loss of reflexes. or if someone's had a spinal injury, then they may get a loss of reflexes. Or you may notice that people who've got something going wrong with their gait and they have hyperreflexive reflexes, this may indicate that they've got some sort of brain or spinal cord abnormality. So conditions affecting muscles and peripheral nerves usually result in reduced or non-existent reflexes. So that's the most important thing to remember when it comes to diabetes, because that's going to affect muscles and peripheral nerves. So reduced reflexes are a common symptom of back pain due to degenerative disc disease. Now, in addition to reflexes, it may be worth remembering the fact that if you do have a patient who has suspicious balance issues or proprioceptive loss, it is worth remembering that you can also do a Romberg test. Very simple test. You get the patient to basically, they stand flat on the ground with their hands either side, and you get them to stand there with their eyes open for 30 seconds and then closed for 30 seconds. And if you look at the amount of sway that goes on, or they're unable to stand up with their eyes closed, then quite often this is a sign that there's some sort of abnormal proprioception going on. It's not a specific test, but it is a really quick and easy method to detect some more profound balance issues. So I'm just going to talk about diabetic neuropathy again. As we've mentioned, just in case you've missed it, the first sensory loss to go is typically the vibration sense, and we're going to be talking about a 128 Hertz tuning fork, which may be accompanied by some level of proprioceptive changes. The secondary sensory loss is going to be pressure sensation, and as I've already mentioned, the 10-gram Semmes-Weinstein monofilament is not normal sensation, that is loss of protective sensation, so that will be more significant loss of sensation. The first reflex to be lost is typically the Achilles tendon reflex, and that's because it's a much longer nerve. Just as an aside, people with longer nerves, so therefore taller people, tend to have more issues with sensory loss than shorter people. So first, the Achilles tendon reflex is the first to go, followed by, in more severe cases, the patella reflex. Now, there are some conditions, neurological conditions, affecting the lower limb, which is worth being aware of. Now, you would have already covered or heard of neuromas. And neuromas, typically, if we talk about a neuroma in the foot, we're typically talking about the classic Morton's neuroma, which is the one that occurs between the third and fourth metatarsals, around the third and fourth toes. So you may be able to pick that up through sensory loss, but typically you're going to push on the neuroma and notice that it's particularly sore when you push on it, because it's essentially a rubbing issue against the nerve. Diabetes, clearly we've mentioned that already. Back problems, you're going to see a lot of patients with back problems, and it's worth becoming familiar with the various things affecting the lower back. Maybe not a lot of detail, but just become a bit familiar with it. So it's worth becoming aware of the difference between a disc bulge and a disc herniation, because they're not the same thing, and degeneration of the spine. So they're all slightly separate condition. Now, a disc bulge can lead to herniation. Degeneration of the spine can cause a disc bulge or disc herniation. But they are separate conditions, and you should be aware of them so that you can interact with other health professionals. It's worth learning about laminectomies, and you'll see a little picture down the bottom here where we can see when the laminectomy, they're actually removing the spinous process to open up the foramina around the nerve. You should be familiar with the word facet joint, or more accurately, the zygapophyseal joint in the lumbar spine. So these are the little joints that occur here. These quite commonly will become degenerative and end up with osteophytes around them, and those osteophytes compress on the spinal nerves as they come out of the spinal cord. Spondylolisthesis, which is where the vertebrae slip forward. spinal stenosis, which is essentially narrowing. You would have heard of stenosis of arteries. Stenosis of the spinal cord is narrowing of the spinal cord, quite commonly because of osteoarthritis, but can also occur as a congenital abnormality. You should also be aware of the word sciatica. Now, you all know the sciatic nerve, but it's quite commonly a nerve that becomes compressed in the lumbar spine or down through the buttock area, so that can cause something called sciatica. Stroke obviously is an issue affecting the brain, and that can cause loss of motor control. Charcot-Marie Tooth disease, we've already mentioned. I would highly recommend that you become familiar with Guillain-Barré syndrome, otherwise known as GBS, which is an autoimmune disease where you start to attack the myelin around your nerves. Typically, this is a temporary problem, and it can be caused by something as simple as catching a cold or catching the flu. And this can lead to you to develop antibodies against your own myelin, and so that can cause quite significant changes in your peripheral nervous system. Typically it's only temporary, as I say, and most people recover, but there are some situations where people have permanent disability because of it. And in some cases, more severe cases, you can in fact die from it because it can affect the nerves leading to your chest cavity and therefore affect your breathing. You should be familiar with MS, multiple sclerosis. I know that I speak to you a lot about the word sclerosis, which means hardening or scarring. So multiple sclerosis is hardening or scarring in your spinal cord. And that affects obviously damaging randomly different nerves in your spinal cord. And then there's motor neuron disease, a somewhat rare condition, but it is going to be seen now and again, and it's worth just being aware of what motor neuron disease is. Finally, we're looking at the last part of the assessment, which is the ability to demonstrate the technique and explain the reason to assess foot and ankle muscle strength. Now, you can go through all sorts of muscle tests. It is worth probably being aware of the primary ones. The ones I look for are tibialis anterior, tibialis posterior, triceps surae. So if you can isolate those muscles, you're off to a good start, because those are the most important ones that you're going to need to assess. Now, in addition to that, you may want to be able to test the peroneals or the fibularis muscles, but these are the primary ones that I would tend to use in practice. So when you have loss of power in these muscles, it can indicate that you've got back problems. It could indicate you've got MS. It could indicate you've got Parkinson's disease, or you've had a stroke. So there's a variety of things that could cause loss of muscle strength. And the reason we do this, as we say in the assessment, is to detect motor abnormalities and therefore develop diagnoses that may relate to balance issues like Parkinson's, MS, diabetic motor neuropathy, spinal pathology, etc. So I think if you cover some of those things, you'll do really, really well on your clinical exam. Thank you for sitting through this hopefully somewhat interesting presentation on neurological assessment.